Well, why don't we go ahead and get started? Good morning and welcome to Medical Grand Rounds. This morning, I'm pleased to have Dr. Seth Charatz, our lead physician for endocrinology and diabetes, who will be giving us an update on osteoporosis. So thank you, Seth, and the floor is yours.
Great. Thanks for having me. I'm going to talk a bit about osteoporosis and hopefully have some questions at the end. I can answer anything as we move along. Where are we with osteoporosis therapy? Lots of things have changed over the last few years as far as therapies and guidelines, and so it's a good time to kind of review where we are. What we're going to talk about mainly is postmenopausal osteoporosis, which is the most common disease state that we're treating. And we know that along with osteoporosis, there are basically the main thing we're trying to prevent are fractures. And fractures are painful to the patients. They're costly to the healthcare system. So our main goals are preventing fractures so that we don't have these issues down the line. And we have effective treatments available to us to treat osteoporosis and lower fracture risk. If we look, 1 in 2 postmenopausal women will have a fracture in their lifetime. And if you have a fracture, then you're at high risk of having more fractures in your future. The fractures themselves cause pain, decreased mobility and function, and fear. And if a patient has a fracture, there's definitely a decrease in the quality of life. And there can be increases in mortality depending on the ages of the patient at the time of fractures. So over the last 5 years or so, the media and other assorted areas have really focused on a few of the adverse reactions in some of our therapies, like atypical femoral fractures and osteonecrosis of the jaw. And therefore, people are reading and Googling, and many patients are, thoroughly involved in their care, and they look for things about what they're being treated with and side effects. So this uncertainty about the benefits and risks of different management strategies for osteoporosis has really affected the decline in use of medications to help prevent fractures. So there's been a decline in the use of bisphosphonates, and owing to that, recent hip fracture incidence has actually increased in postmenopausal women in the United States. So prior to the last 5 or 10 years, the incidence of hip fractures was decreasing. And this suggests that this leveling off is possibly a reversal in what's been a 15.5-year decline in fractures. So this is concerning. Part of what I'm going to do today is to try and talk to you about how I address these concerns with patients and can kind of overcome some of those barriers to therapy and reducing fracture risk. So kind of an outline on what I'm going to talk about. Who are we going to treat for osteoporosis? When are we going to monitor? And what tests do we do for monitoring? What do we treat with? And how long do we treat? So these are all pertinent questions that I think I'm going to hope to answer in the next hour. There's multiple guidelines on osteoporosis therapy, Endocrine Society, ACP, International Osteoporosis Foundation, ASBMR, And all of them recommend treating postmenopausal women who are at high risk of fractures, especially those who have experienced a recent fracture that were on pharmacological therapy. And the reason that this recommendation is made is because the benefits outweigh the risks. So as in a lot of other disease states, with osteoporosis, it's risk-benefit. What's the risk of a side effect to therapy versus the benefit of reducing the risk of a fracture? So when we talk about risks, we put them into 4 categories. So a low risk of fracture would include a patient who has no prior hip or spine fractures. The bone density, T-score at the hip and spine are both above -1. And they have a 10-year hip fracture risk of less than 3% and a 10-year risk of major osteoporotic fracture of less than 20%. So on a FRAC score on the DEXA report. Moderate risk includes no prior hip fracture or spine fractures. The BMD T-score at the hip and spine are both above -2.5, or the 10-year hip fracture risk is less than 3%, or the major osteoporotic fracture is less than 20%. So moderate risk, if you compare, worse bone density at the hip. High risk patients are classified as having a prior spine or hip fracture, or a bone density T-score at the hip or spine of -2.5 or below, or the higher 10-year hip fracture risk greater than 3% and other osteoporotic fracture risk greater than 20%. And then the very high risk category includes multiple spine fractures and a BMD T-score at the hip or spine of -2.5 or below. So these are the categories that we use for risk assessment. Let's talk a little bit about therapies. The goal of any pharmacologic therapy to treat a low bone density or osteoporosis in postmenopausal women is to decrease the burden of fractures, of osteoporotic fractures. So it is not to increase bone density, okay? What we're looking to do is decrease fracture risk. And treatment thresholds are based either on the bone density T-score or the various risk assessment tools, such as the FRAC score. So the data that we have suggests that a recent fracture within the last 2 years is a better predictor of an imminent fracture. So if you have the risk of fracture within the next 2 years is a better predictor of future fractures than a fracture that you had over 5 years ago. So this is true for vertebral fractures and non-vertebral fractures, like wrist fracture or a humerus fracture. And in these situations, pharmacologic therapy should be initiated without delay in patients with a recent fracture to prevent more fractures, because their fracture risk is higher. So patients with a more recent hip fracture, for example, those are the patients that should be treated. A lot of the treatment therapy recommendations are country-based. So I'll focus a bit on the US. And in most of the guidelines, pharmacologic therapy is recommended for postmenopausal women with hip or vertebral fractures, those with T-scores of -2.5 or less in the femoral neck, total hip, or lumbar spine, those with T-scores of -1 to -2.5, so in the osteopenic range, and a FRAC score, 10-year probability risk of fracture greater than 20% of any fracture, or greater than 3% for a hip fracture. The bone mineral density T-score is defined as the number of standard deviations from the mean bone density of white females who were 20 to 30 or 20 to 29 in the NHANES survey. So that is what when we look at T-scores on a bone density, we're looking at comparing the bone density of that patient to that of a healthy 20 to 30-year-old female, and assessing the standard deviations and assessing the distance away from that patient. So for the treatment of osteoporosis, only the lumbar spine, the tonal hip, and the femoral neck bone density T-scores are considered. When we're talking about therapy and counseling in patients, and women especially, they should be counseled regarding adequate calcium and vitamin D intake, how to prevent falls, stopping smoking, avoiding excess alcohol, increasing weight-bearing exercise and muscle strengthening exercise, as well as balance training. So those things are important in the non-pharmacologic realm. But once osteoporosis is diagnosed, strategies to prevent the subsequent fractures, those strategies above and also pharmacologic, they need to be reinforced indefinitely. So we have to look at osteoporosis much similarly to other chronic disease states like hypertension, hyperlipidemia. We're constantly seeing patients in follow-up and reinforcing some of these disease state strategies. So this is not a treat and the patients are okay afterwards. This is really lifetime monitoring and support for osteoporotic patients. This is the Endocrine Society recent guideline on therapies for osteoporosis. And we're going to dive into this a bit. I'm going to talk about all the different therapies. But starting off, how this guideline is really structured is lifestyle modifications, determining the fracture risk, and then categorizing patients into low, moderate risk, high, or very high risk, and then determining which therapies we should use, monitoring those therapies, and then monitoring the patients. So the therapy that we've had for a long time is bisphosphonates. So we're going to talk about bisphosphonates. Bisphosphonates are indicated in postmenopausal, in the treatment of osteoporosis in postmenopausal women who are at high risk of fractures. And that's the recommended initial treatment therapy. So how do the bisphosphonates work? They inhibit osteoclastic activity. We see here they promote the osteoclastic apoptosis. They're released locally during bone resorption. And basically, they're decreasing osteoclastic activity and allowing osteoblastic activity to occur, therefore improving bone density. So the bisphosphonates currently that we use, a majority, are listed here. Alendronate is the oral therapies. Alendronate is once weekly. Abandronate is monthly. Risandronate is weekly or monthly. The IV formulations of bisphosphonates are zoledronic acid, which is an annual IV infusion, and abandronate, which is quarterly. The main therapies that we're using currently are usually the alendronate and the zoledronic acid, as well as the abandronate. So we can look at some meta-analysis of fracture reduction treatment up to 5 years in these therapies. These therapies have been around for a fairly long period of time. There's good data on fracture risk reduction. So what we're looking at here is a meta-analysis of all the studies looking at fracture risk reduction. And most of these studies were done in older women who were greater than 65 years old. They had a high fracture risk, low bone density, and prevalent vertebral fractures. So looking at alendronate versus placebo, there's in a meta-analysis about a 44% risk reduction in vertebral fractures, 40% reduction in hip fracture risk, and 17% reduction in non-vertebral fracture risk. For abandronate, 31% reduction in vertebral fracture risk, and there was no evidence in reduction in hip fractures or non-vertebral fractures. So when we're, these are effective therapies in reducing fracture risk. So that's why these medications are used. If we look at a meta-analysis of the zoledronic acid versus placebo, there's a 56% reduction in vertebral fracture risk, a 42% reduction in hip fracture risk, and an 18% reduction in non-vertebral fracture risk. So again, very robust and effective therapy. In post-hip fracture studies in men and women, that's been found to show a 35% reduction in all clinical fractures. So these medications do work to reduce your risk of fracture. What about beyond 5 years of therapy? So with the bisphosphonates, the positive effects persist for several years after discontinuation. The trials we can look at there are trials with long-term use. There's a alendronate trial, 10 years versus 5 years, and there's a zoledronic acid trial, 6 years versus 3 years, okay, of therapy. In the FLEX trial, which is the alendronate trial, the bone density decreased gradually in the placebo group compared to the continuing the alendronate in the alendronate group. At the end of 5 years, 50 to 75% of the bone density gains during the initial treatment period were lost in those who stopped alendronate, and bone turnover gradually increased. Among those who continued the alendronate, the fracture risk was significantly lower, and you see there was still they held on to the bone density gains, although not 100%, but still 50 to 25%, 25 to 50%. And there was no significant reduction in a non-vertebral or hip fracture in this study. The zoledronic acid extension study, bone density fell more slowly, and the bone turnover markers rose more slowly after discontinuation compared to alendronate, but the fracture results were similar. So reduction in risk of fracture, even with a discontinuation of therapy. Another therapy that we use in the anti-resorptive realm is Denosumab. And Denosumab acts differently than the bisphosphonates because it binds rank ligand and inhibits osteoclast, but it still inhibits osteoclastic formation just by binding rank ligand. And you can see here the bone formation, the perfusion of the osteoclasts, and the inhibition of the formation and function of those osteoclasts with rank ligand inhibition. And at that time, by stopping the osteoclastic function, you inhibit bone resorption. So what do the studies look like as far as fracture risk reduction with Denosumab? You can look at a meta-analysis, and 68% reduction in risk of vertebral fractures, 39% reduction in the risk of hip fractures, and 19% risk reduction in non-vertebral fractures. So 68% reduction in vertebral fractures is pretty impressive. And we can look at the Freedom Extension trial, which goes out 10 years total therapy with Denosumab, and there was a stable fracture risk reduction up to 10 years. So continuing the medication up to 10 years, stable, that risk reduction was steady throughout the 10 years study. The issue with Denosumab is the bone density gains are rapidly lost when you discontinue the medication. So it's given an injectable form every 6 months. If you discontinue the medication, bone density gains are lost. So in that case, if you're going to discontinue Denosumab, another therapy like bisphosphonate should be given to maintain those gains, at least for a year. And it depends on the therapy. Oral alendronate or even zoledronic acid has been studied, and they do help preserve the improvement in or the increase in bone density. The adverse risks to Denosumab, there is an increased risk of infection and eczema because it's a monoclonal antibody therapy. Fatal infections were very few, were not statistically significant. There was no increased risk of malignancy, the benefits of denosumab are it can be used in patients with chronic kidney disease as opposed to bisphosphonates. What about the adverse events with bisphosphonate therapy? So, the two main adverse events that physicians, dentists, patients are concerned about is osteonecrosis of the jaw and abnormal femur fractures. So I want to talk a little bit about osteonecrosis of the jaw. What is it? It's a non-healing wound in the oral mucosa, and that's with express bone, and it lasts greater than 8 weeks. It's usually associated with an invasive dental procedure, such as an extraction or an implant. If we look at the numbers, the absolute risk of ONJ, or osteonecrosis in the jaw, in osteoporosis patients range from 1 in 10,000 to 1 in 100,000. So we can look at the percentages there. What the increased risk of ONJ is actually seen more with higher doses and frequent use of bisphosphonate therapy and denosumab. And that was usually seen in the oncology setting. So when these drugs are used in the oncology setting at higher doses, we see more events of osteonecrosis of the jaw. In osteoporosis patients on long-term bisphosphonate therapy, greater than 4 years, the risk of ONJ has been reported to be as high as 21 in 10,000. And you can see that's less than 1%. So currently, the American Dental Association does not recommend stopping bisphosphonates for dental procedures. If a tooth is extracted or an implant is planned or ongoing, then they do recommend deferring therapy until the area is healed. If we look at the American Association of Oral and Maxillofacial Surgeons, they recommend a 2-month drug holiday for those who've taken greater than 4 years of bisphosphonates. I'm not sure how that works with zoledronic acid, since it's been once a year, but certainly for the oral therapies, holding them for 2 months if they've been on bisphosphonates for greater than 4 years. What are the other kind of major adverse event that patients talk about is atypical femoral fractures. So these are insufficiency stress fractures of the femoral shaft. The patients present with a pain or an aching in the thigh or the groin with or after weight-bearing activities. And this calculation of the atypical femoral fracture incidence is really kind of difficult to get a handle on because it's restricted to studies with radiographic evaluation and evidence. And the incidence appears to be very low. We can look to Sweden and their national data study. There were 3 atypical femoral fractures per 1,000 hip fractures. And we can look at the Kaiser Northwest panel of patients. Again, a very low atypical femoral fracture incidence, 5 per 100,000 person years, compared to a 100-fold higher incidence of garden variety hip fractures. So there is a stronger increase in the atypical femoral fractures with longer duration of bisphosphonate use. In a study out of California with an HMO, if we look, the atypical fracture risk for 2 years of bisphosphonate use is 3 per 100,000. If you're on bisphosphonates for 5 years, 20 per 100,000 years, and 8 years, 50 per 100,000 years. But the benefits in reducing hip and osteoporotic fractures in overall therapy is strong. So if you treat 1,000 osteoporotic women with bisphosphonates, you prevent 100 fractures. So it's really what we're looking at is a risk-benefit analysis of benefit of the reduction in risk of overall fractures versus the risk of these atypical femoral fractures as well as ONJ. So we're getting to my favorite slides that I kind of actually have translated when I'm having discussions with patients on treating osteoporosis. So everything is risk benefit. What's the risk of a side effect versus the benefits of therapy? So if we look at this chart, this is taken from Sweden, and we look at the risk per 100,000 people per year. The risk of any fragility fracture is about 2,600 per 100,000 people years. If you look at your risk of a hip fracture over the 10 years, it's about 385. Your risk of anaphylaxis from a penicillin shot is 32 per 100,000 people years. Your risk of dying in a motor vehicle accident is 11 per 100,000 people years. Your risk of dying by murder is 6. Your risk of getting osteonecrosis of the jaw in an osteoporosis patient is less than 1. And that's about equal to being struck by lightning. Okay, so what you're looking at is comparing the risks of garden variety things versus the risk of getting ONJ, and it's about equal to getting hit by lightning and dying. We can look at another way to kind of look at that or discuss is probabilities of fractures and other adverse events. So in an 80-year-old woman with a T-score minus 3.3, her risk of fracturing, if she's not being treated, is 25%. If she's treated with therapy, that risk of fracture decreases in half by 12.5 to 12.5%. The risk of ONJ or atypical femoral fracture, you can see here. The risk of getting ONJ is less than or is 0.01. The risk of atypical femoral fractures in a treated patient is 0.5%. The risk of getting into a fatal car accident is a little bit higher, 0.11%. And again, the risk of murder and dying is 0.06%. So if you put these into context, I think you get an idea of the risk of ONJ and atypical fractures in therapy. Again, going back to benefits and risks, you can kind of compare motor vehicle accidents and osteoporosis. So if we look, 2.3 million adults treated in the ER each year for injuries from a motor vehicle accident, and there's 2 million osteoporotic fractures each year. So the risk of injury and death you see there. If you wear a seatbelt, you reduce your risk of a serious injury by 50%. If you get treated with bisphosphonates for osteoporosis, you reduce your risk of fracture by about 50%. What are the risks of seatbelt injuries? Not a lot. Pretty much close to zero. And the risk of ONJ and acute or atypical femoral fractures, again, are less than 0.5%. So you have to have these conversations with patients, trying to make it real world to get them to understand. Do adverse reactions happen and adverse events happen? Yes. That's with pretty much any therapy that we use as physicians in any disease state. So having these conversations and discussing them, I found has kind of enlightened the patients on the risk and the benefits of treatment. And there's still patients that do not want bisphosphonates or these therapies, and that's okay, as long as I've given my best evidence and discussion on the after effects of not taking any therapy. So with the osteoporotic fractures and the risks, there's been a discussion about drug holidays. So this has been prompted by the atypical femur fractures and the ONJ risk with long-term bisphosphonate therapy. So there was a ASBMR or bone, basically the Bone Society task force. And at that task force, the decision was made to recommend that after 5 years of oral bisphosphonates or 3 years of IV bisphosphonates in patients who are not at high risk of fracture, a drug holiday is actually appropriate or recommended. And what's a holiday? So it's a temporary discontinuation of the bisphosphonate for up to 5 years. Now, this could be longer depending on the bone density and the clinical circumstances of the patient. The evidence is stronger for the retention of the benefits during a holiday for alendronate and zoledronic acid. That's where there are those randomized extension trials. And a shorter reassessment period of 3 years is more appropriate for the annual IV zoledronic acid based on the evidence from the randomized controlled trials showing residual effects after 3 years of annual use. So bisphosphonate holidays are recommended in postmenopausal women with osteoporosis who are taking the bisphosphonates. Those patients, if you discontinue the bisphosphonate and put them on a holiday, we need to reassess their fracture risk after 3 to 5 years. So women who remain at high risk of fractures, going back to that initial slide I had, should continue the therapy because it does reduce the risk of a serious fracture. Those who are at low to moderate risk of fractures should be considered for a bisphosphonate holiday. And once the holiday is initiated, we need to reassess fracture risk at 2 and 4 year intervals and consider restarting the therapy earlier than the 5 year maximum if there's a significant decline in bone density, an intervening fracture, or other factors. So again, this gets back to constantly monitoring the patient's bone densities every 2 years, assessing risk, and determining if restarting therapy is appropriate. Other therapies that we have for osteoporosis, anabolic therapies. So that's Teriparatide and Abaloparatide. These are PTH and PTH-related analogs. They're recommended in postmenopausal women with osteoporosis at a very high risk of fracture. And they, the intermittent increase in PTH increases bone formation. So that's how the therapy works. And we can see here the bone modeling cycle, osteoblastic activity is seen on the left. The bone absorbing cells dig deep pits into the bone, and Forteo increases the number of the bone forming cells, which then fills the pits are filled with new bone, and a new bone layer is formed. In studies, there's been a 74% reduction in risk of vertebral fracture and a 39% reduction in risk in non-vertebral fractures with Teriparatide. And the therapy is for 2 years. And the reason that the therapy is for 2 years is because there was an increase in osteosarcoma in rats. And therefore, the FDA recommended 2 years of therapy. Since 2002, there's been over 1 million users of Teriparatide and Abaloparatide, and there was 1 case of osteosarcoma as of 2016. So the translation to humans was not seen so far in real-world studies. To maintain these anabolic effects, the anabolic effect is discontinued after the medication is discontinued, and that's why after treatment with Teriparatide, bisphosphonate therapy is recommended. There's a question of, is the therapy as efficacious being given after bisphosphonate therapy? It is, but the magnitude of effect is somewhat blunted. Other medications we use for osteoporosis, selective estrogen receptive modulators, or SERMs. They're recommended in patients who are low risk of DVTs, for patients who bisphosphonates are not appropriate, and for patients who are at a high risk of breast cancer. So raloxifene is the main therapy we use. There was a 40% in the studies, 40% reduction in risk of vertebral fractures, no effect on hip or non-vertebral fractures. And these therapies should be considered in younger women with osteoporosis. Other options that we use less often, estrogen with or without progesterone. Calcitonin, actually the trials have never really been powered to show risk reduction in fractures in calcitonin. It's not really used extensively at this time. And then what about calcium and vitamin D? So in the studies, calcium and vitamin D, the greatest risk reduction in fractures is in elderly individuals living in residential care in the studies. The recommendation for calcium and vitamin D, total calcium intake for patients should be 1,200 milligrams a day, and vitamin D levels should be greater than 20. Newer therapy is Romosozumab. This is a sclerostin binding treatment, monoclonal antibody. It's an anabolic agent that also reduces bone resorption. It's given once a month for 1 year. And in the studies, there was a 73% reduction in risk of vertebral fractures and no effect on hip or non-vertebral fractures. And it's recommended just like Teriparatide and the PTH agonists, follow-up therapy with bisphosphonates after the 1 year treatment. Here is how the sclerostin antibody therapy works. It works both to increase osteoclastic activity and also it inhibits the, it increases osteoblastic activity and inhibits the osteoclastic activity. Adverse events in Romosozumab. The ARCH study was 1 year of Romosozumab followed by 1 year of alendronate, and that was compared to 2 years of alendronate. There was an imbalance in the MACE in year 1. Major adverse cardiovascular events, 50 versus 38. This was a study of a little bit over 2,000 women. There were 12 cardiovascular deaths in the alendronate group versus 17 in the Romosozumab group. There were 6 cardiac ischemic events in the alendronate group versus 16 in the Romosozumab group. And there were 7 CVAs in the alendronate group versus 16. So these differences in the adverse events raise the possibility that alendronate might reduce cardiovascular events and that the effect of Romosozumab may not be significant, but it didn't make a lot of sense. But even though there were small numbers, there is a box warning to use this in caution in patients who are at risk of MI, stroke, or CV death, especially those that have had an event within the past year. So going back to the Endocrine Society guidelines, you can see in the very high-risk population group, the recommendations on bisphosphonates, denosumab, and other therapies, reassessing and adjusting therapies based on the adjustment of risk. And I'll dive a little bit back into this, but the approach to the treatment, the goal in treating osteoporosis is to decrease fractures. So we want to promote good bone health, maintenance factors like calcium intake, vitamin D intake, exercise. Oftentimes our choice of therapy has to take into account the cost. And that's the reason why bisphosphonates are often used as initial therapy, because they are low cost. And at all times we have to weigh the risks and the benefits of therapy. So a couple of examples. We have a 58-year-old woman with osteoporosis and a high risk of breast cancer. This patient would we should consider raloxifene in this patient. a 60-year-old woman with reflux and a high risk of fracture, we may want to start Denosumab or zoledronic acid instead of an oral therapy. Theoretically, you can choose anabolic agents like Teriparatide or Romosozumab first. However, usually we are not able to do this due to the cost and the insurance step therapy requirements. So in an ideal world, we would want to give anabolic agents, build up bone density, and then preserve the improvements with bisphosphonate therapy. But it often does not happen that way. What about switching therapies? When we're switching therapies, we have to take into account the availability, the cost, the tolerability, patient preference, and adherence. So when do we decide to switch therapies? Well, we can look at if a therapy is failed or not. So osteoporosis therapies do not eliminate fracture risk. So there's plenty of patients, unfortunately, who are on therapy and despite that still have a fracture. So if you have a fracture while on therapy, that's not necessarily a failure. What we can consider a drug failure is the loss of bone density greater than the least significant change. If it's greater than 5% in the spine, 4% in the hip, and 5% in the femoral neck over 2 years. So if we have a patient on therapy and we see a decrease in bone density, then that could be considered a failure of therapy. Stabilization of bone density or keeping a steady bone density without a decrease is actually showing effective therapy. Another way to check for failure of therapy is bone turnover markers. And we should see bone turnover markers decrease on anti-resorptive therapy. If you have 2 or more fractures while on therapy, especially vertebral fractures, then I would consider that a failure of therapy. And in all of these cases, we should rule out secondary causes of osteoporosis like other medications, other medical conditions like multiple myeloma or other issues. So if we make the switch from an anti-resorptive therapy to a bone formation therapy, there's really a lack of evidence. But women with recurrent vertebral fractures due to osteoporosis, a high fracture risk on long-term anti-resorptive therapy, it would be indicated to try anabolic treatment. A woman with ONJ or atypical femoral fracture who's on anti-reabsorptive, that would also be a candidate for anabolic therapy. And an alternative to the failure of therapy model is a treat to target bone density. So we could choose the therapy for target bone density and change to a more potent agent if we're not at goal, and we can stop when the fracture risk is at an acceptable level. So we should be constantly monitoring patients for fracture risk, side effects to therapy, and then adjusting as we move forward. I hope I gave you a kind of ballpark drill down on osteoporosis therapy. I kind of just want to stress that this is really now it's become a chronic disease state that we need to take into account and almost treat similarly to other chronic disease states like diabetes, hypertension, hyperlipidemia.
So we do have a couple of questions. I think you have time to get through most of them. So Dr. Reynolds asks, do bisphosphonates interfere with bone repair or healing? And if so, how long after an acute fracture can bisphosphonates be started? So should the hospitalist seeing these patients consider doing it, or put it in the discharge summary, or what would you recommend?
So, yeah, there are studies where we certainly, the issue really is missing the boat on treating these patients. So if patients have a hip fracture and are seen in the hospital, really they can be started on bisphosphonate therapy at that time. And there's studies that have been showing that it actually improves or decreases the risk of future fractures. So yeah, I mean, my recommendation, and there are plenty of examples of fracture services in the hospital, where patients that have a hip fracture automatically get a referral to endocrinology or another service, and those patients are sent home with bisphosphonates, because the decrease in risk of fracture is much higher, and it does not impair the bone healing over time.
So a related question, Jeanette Altavella asks, tell us how you've partnered with the ED, urgent care, and radiology providers to encourage them to tell patients with new fractures to follow up with their PCP regarding bone density. And and GRIPA would like to help get this partnership started.
Yeah, I'm all for collaborative care. So I think we are certainly missing a majority of patients that are at high risk of fracture. Yeah. I would be more than happy to help coordinate with GRIPA and other agencies. So get in contact with me and we can set something up. But these are certainly within a large health system, there should be ways to reduce the risk of fractures and get these patients evaluated.
Yeah. So Mary Cohen makes the point of distinguishing relative risk from absolute risk. And you talked about fracture risk reduction, that was relative risk, but ONJ was absolute risk. So could you comment on that? Yeah.
Certainly. Again, I was kind of just putting up, trying to bracket the relative and absolute risk. I agree.
Yeah.
But I think then, in my opinion, again, it all comes back to risk benefit. And yeah. I think there's been a disservice sometimes to overstating the risk of these of ONJ and AFF and not looking at the benefit of therapy.
So what are your suggestions with patients with chronic kidney disease or ESRD?
So certainly, with chronic kidney disease, the recommended therapy or the indicated therapy would be Denosumab. In patients with end-stage renal disease, there's really not a lot of data supporting treating with bisphosphonate therapy or anti-resorptive therapy. And that's mainly due to the metabolic bone disease of those patients on dialysis and with end-stage renal disease. So it's not indicated in those patients, but in patients with mild kidney disease that are at high risk of fracture, those are the patients that we really should look at for treating.
Yeah. So D. Jackson says if a patient has an osteoporotic fracture, they are high risk. Can the bisphosphonate be stopped after 5 years?
Yeah, in those, in general, the guidelines are high risk treatment for 3 to 5 years, then a bisphosphonate holiday, and then monitoring. So, and it would be a bone density again in 2 years, and then determination of risk at that time, and then determine if restarting bisphosphonate therapy is appropriate.
And then when do you start your first DEXA? Any age recommendations?
I believe it's 60, postmenopausal women at 60, 60 or 65. I think it depends on the society. But
And then there's a question on the other side too. How old is too old? At what age do you consider not initiating therapy?
So if if you're plugging in data into the FRAX score, so yeah, I think again it's all risk. A 90-year-old woman with no chronic conditions other than osteoporosis who was never treated, what's her bone density? Is the hip bone density, -3.5, -4? I would, in my opinion, the patient would be high risk of fracture depending on where they lived in their lifestyle. That's a discussion you have to have with the patient, though. If you plug the age into the FRAX score and their bone density is like -1, they still come out to a higher percent risk of vertebral fracture versus and hip fracture. So, it's really patient dependent, basically.
Yeah. Dr. Garg asks, are stress fractures like metatarsal fractures taken into account when initiating or changing treatment?
So that would be a non-vertebral fracture. So yeah, in that area, then yes.
And then I think we can sort of end with this question. URMC has a dedicated osteoporosis center in their orthopedics unit. What does RRH have? Is it you guys? Is it somewhere else? When and where should patients be referred?
It's us.
It's you.
RRH endocrinology. We do the same thing as the bone center.
Yeah. So
the bone center.
when should people refer to you, I guess?
I see patients who have a discussion with their primary care physicians and don't want to start therapy. I'm happy to have a discussion with patient, start therapy, and have them follow up with their primary doctor and monitor. Patients with severe osteoporosis, we do the zoledronic acid infusions here in our office. We do the Prolia injections here in the office. We're pretty skilled with the insurance approval. We use all the therapies. That's all that's there. So we will consult with anyone. If you send a consultation for osteoporosis, we'll see it here in our office. Any of the RRH endocrine offices, both on the west side and east side.
Great. So you guys are the Osteoporosis Center for.
Yeah.
All right. Thank you. That was great. And with that, I'm going to stop the recording and say thank you, everyone. See you next week.
Thank you.